Okay, welcome to the Pain Exam webcast. And today we're joined by Rachel Trobman, CEO of Upside Health. And a few announcements before we begin. For those of you who are taking board review, we're revising the Pain Exam website such that the newest material and bonus material is located on the NRAP Academy's website. Just go to NRAP, N-R-A-P, pain.org, or just go to Pain Exam. There's a link to refer you there. We also have ultrasound courses every month. The next two are in New York and Charleston, South Carolina, as well as a regenerative medicine course. Lots of great conferences coming up: ISPN in Dubai, NICIP in New Jersey, New York Pain Symposium Congress, I should say, in Jersey, and the EPA, NANS, a lot more coming up. And I've been asked to run the ultrasound course at the West Virginia SIP meeting this spring, so I'm really excited to do that, and I hope to see you there. So Rachel's been on the show about 3 or 4 times now, I think, and it's always great to have her here because she's really good with coding and all the stuff I'm pretty bad with, and I think my ADD kind of prevents me from absorbing. So it's always nice to get refreshed as well as to hear the latest updates. And Rachel, welcome.
Thank you, David. It's really good to see you again. It's one of my favorite times of year, the time when we discuss the proposed physician fee schedule and all the challenges and opportunities it holds.
It's a scary time of year. Someone's
It's
always
true. I mean,
trying
it's
to
not.
lower our salary. So,
Oh yeah. Well, then you're not going to like what I have to share with
oh
you
God.
today.
Well, then it's a good thing you guys are here listening to this because she's going to update us and help us prepare for what's to come and hopefully help us navigate it. So, Rachel, I made you host. Why don't you just dive into it?
Yeah. Yeah. Let's get started and answer many questions along the way. So, before we get started, just a quick disclosure, hold on, is for those of you who have not met me before on one of these, I am not an attorney. I am just speaking based off of my experience in the space, leading a digital health company. I've been doing so for a little over a decade. My work has been funded by the NIH, Yale, a few noted foundations. And another important thing about me is I really like questions. So please use the Q&A function at the end of this webinar. And I look forward to hopefully address some concerns or any challenges that you have. So this evening, I want to cover 3 key things. One are the proposed changes in the proposed 2024 fee schedule at a high level. Then look at some opportunities that are being presented. And then third, really how, based off of my experience with our company, we've been able to optimize those opportunities. And then, of course, as I mentioned, end with a Q&A. So starting with some unfortunate news, you may have seen, there is a 1.25 rate decrease in the 2024 physician fee schedule across the board. Not great news is kind of an understatement, but it exists. I think hopefully there was, they always solicit feedback. I think it was due September 11th. And I know that, many organizations, associations really fought back against those decreases. So we'll see where things net when they put out the final fee schedule in November. And other changes, increase in MIPS thresholds. So, decreasing the rates and increasing the MIPS thresholds, I think from 72 to 84, somewhere around that. It's the first time they've increased the thresholds in 2 years. So it was kind of bound to happen. But those are definitely some challenges that we should be aware of, especially if you're running a practice. On the flip side, there are some promising additions or expansions or solidifications. One of them is solidifying a lot of the telehealth flexibilities that were introduced during the public health emergency, particularly related to where you can be located when you're providing services. The other thing that's interesting, particularly in this space of specialties that handle complex patients, are some new add-on codes. There are going to be some new G codes that are supposed to address the additional time and resources that are required for complex patients in both the primary care and specialty care setting. We saw a little bit of that last year, David, if you remember, with the new chronic pain management codes, the G3002 and 3003, but there's a word is apparently a whole new group of these codes that should be coming out that are a little bit more general than the specific nature of those chronic pain codes, and should provide a little bit more opportunity to offset the potential decrease in payments. But now we're getting to the meat of what I know the most about, and these are changes related to all the remote care codes. But before I get too much into them, I want to explain what constitutes remote care. So remote care and telehealth are different from telemedicine. So telemedicine is a patient encounter, a patient appointment that could happen in office, but instead is happening virtually. It's a virtual visit, pretty much, is what telemedicine constitutes for. And most of the CPT codes around telemedicine are just that. Can a visit that's virtual be covered by insurance? And if so, at what rate? These other kinds of codes, RTM, RPM, CCM, CPM, BHI, they're all remote codes, meaning that they can be provided outside of care, often under the general supervision of a physician, but are not necessarily face-to-face video encounters or assessments.
Does the person
Do
have
you
to be,
remember? Oh, go ahead.
Sorry. Does a person have to be a clinical PA, APP, or a physician, or could it be an MA? Who has to look at that stuff?
Well, so the details of the code really it's very, very different. And it varies state by state. So in most cases, these services have to be rendered by a qualified healthcare professional. Now, the definition of qualified healthcare professional changes by state. And primarily these services are rendered by an RN, or some cases an MA, some cases an LPN, but they're all done under the general supervision of a clinician or a physician. And that physician can be an MD, an MP, a PA. Some of these codes, like RTM, can be ordered by an OT or a PT. And as I continue adding acronyms all over the place, David, do you remember what any of these acronyms mean?
RTM is remote therapeutic monitoring.
There we go. And how about RPM?
Remote, I thought it was patient monitoring, but that's not it, is it?
It's physiologic monitoring. So RPM,
right.
Correct. Actually, David, is okay. There's somebody who has a question right now. We'll go a little
absolutely.
out of order. Yeah,
Yes.
I don't want them to wait. Okay. I don't know how to, let's see, how to talk.
All
right.
Here.
Hi, I think you should have permission to add new. Do you have a question?
Let me take his mute off.
Oh.
CPM used to be only for providers, he says.
Yes, so that's a great question. So CPM is one of the few codes I was going to say that cannot be rendered under general supervision. So CPM is the time spent by a physician, but a lot of these other services are required as part of the care plan, as part of those CPM codes. So you'll notice in like the services rendered, you may be remote monitoring, it may be behavioral health intervention. So utilizing these other services can help provide the additional time for CPM. Hopefully that is clear. That has not changed, although there's been a good deal of requests to change that. So David, I'm going to run through these really quickly in terms of acronyms, but we'll talk about the details of them later. So RTM, remote therapeutic monitoring, RPM, remote physiologic monitoring, physiologic measurement, CCM, chronic care management, PCM, principal care management, TCM, transitional care management, CPM, chronic pain management, as we spoke, and then BHI are the behavioral health integration codes. So one of the big changes, or it's a little bit more of a clarification to be specific, is that mixing and matching or creating using a combination of these codes for a patient is allowed. A lot of providers, including us, we're helping support providers use a multitude of these codes because it was never not allowed, but more specifically in this physician fee schedule, they acknowledge that it is allowed. So it's a small difference, but one that helps validate and verify being able to utilize these together. And what this means is you can, one, provide extended time and services for patients that need more than just one of these services, but it also creates additional revenue opportunity for practices, because rather than offer one service for $45 per patient per month, when you add these services and solutions together, you can really increase relatively quickly the revenue opportunity for a practice while providing enhanced care. And these services can be rendered by two different providers. So a primary care doctor could order CCM, chronic care management, and a pain doctor could order RPM, and that would be okay. Or the pain doctor can order both. So there is some flexibility. The one thing that still is a question mark, and rather than create clarification, they created more confusion, is in regards to whether RTM and RPM can be offered together by the same provider or even different providers. So we are waiting for some more clarification on that. But I really think that being able to provide a multitude of the best services for that patient without being limited based off of what the patient is already being offered is truly a great opportunity, because once you introduce a patient into one of these programs or services, you want to be able to maximize it. The second thing is, again, another one of those small word, big impact changes. So when RPM, remote physiologic monitoring, first came out, there was no specific requirement for the number of days that required, monitoring or data transfer. They then changed that to 16 days of 16 days of data collection and transfer. When RTM first came out, same, there was no real specific. They then added that as well, the 16-day requirement. But in the latest version of the proposed physician fee schedule, they changed the word from 16 days of data transfer and collection to 16 days of monitoring. And that difference could mean that rather than have 16 days where data was collected and transferred, that the monitoring is happening over 16 days, but there may have been individually less specific days of data points. We should get some more clarification on that, hopefully, although they haven't been very specific around that in the past. But I think it's a really important thing to note, because anybody who is going to be proposing a partnership with these programs with you, knowing the details around monitoring versus data collection. How are you going to get those 16 days of data? How do you justify it? All really important. And then the last change that I wanted to note today is really in regards to a high level of importance in the space of, pain, orthopedics, everywhere where surgery and procedures are a big part of the business. Previously, in many cases, anyone who was in that global surgery period after a procedure, I think it was like somewhere between 30 and 60 days, sometimes as long as 90, couldn't be billed for RTM and RPM services during that period of time because it was considered part of that global surgery payment period. Well, effective in 2024, that's no longer the case. So these services, rightly so, can be offered after that period of time where monitoring is often most needed. Gonna take a breath for a sec before I get into the importance of that. Was there anything that I ran through right there that you had specific questions on, David, or that was not clear?
No, I think it's pretty clear. It's just amazing the vagueness of the 16 days. It's like it's one of those traps where they're waiting for us to fall into it so they have an excuse not to pay us.
Yep. And so I think that it's really important when you work with a vendor that they are being super judicious and very, very clear about what are the days that are being data is being collected, it's being monitored, what is the documentation that you have for that data collection and transfer and monitoring. But I think there's also confusion because they've gotten a great deal of pushback because there's a lot of monitoring that needs to happen that doesn't need 16 days of data collection. You don't need every other day or every day consecutively for a week certain data points to get a better picture of things.
Right.
So all of these codes and opportunities that I spoke about, why are they important? Like how do they actually get used in a clinical setting? Why do they get used in a clinical setting for maximum impact? Why are they exist? Well, just to give a little bit of credo to how I can talk about this, our solution has been used by more than 31,000 patients and now counting. Integrated in 7 EMR. Thank you. I've been integrated in 7 EMRs. Have clients in 9 states and growing. I think at one point we've had 11. Things change, and so we've been able to see how these codes and these services work in practice, and have developed, some obviously best practices on our account, but really red flags, things to look for, and real opportunities. So we're here because in order to remain in medicine, we need to be able to grow and continue to grow from a revenue perspective. And so one of the advantages of these service codes is allowing for significant repeatable revenue pretty much from month one. And at the very least, break even for the services provided. And that's really important. There are going to be costs associated with these programs. RPM, you need to front the device costs. Other services, you're going to have integration fees. That being said, these codes are billable and they are being paid. And so, there are certain things that you implement into your practice and you don't see payment. You don't see the return on investment for 6 months, 9 months, 12 months. And that's really hard when you're operating with low margins and, inconsistent cash flow. And so this is something that, you can say that happens. And you can do it without bringing on additional FTEs if you're working with the right partner. I don't say that there's no work involved, because anything that is going to bring, value to your patients and your practice is going to have work involved.
How long how long until a practice is up and running, and how long until the practice is profitable?
Yeah. So we normally say, so in terms of up and running, it really depends on like your vendor, your partner, and what suite of services that you're going to offer. And then the other is like depending on your EMR, right? Certain EMRs, if you're integrated with, are really easy. Epic is just not, right? Like there are certain changes, but with a cloud-based EMR that's not Epic or Cerner, between 2 and 4 weeks, typically,
Okay.
sometimes even sooner. Epic, depending on the integration, we've done that as fast as a month.
That's to be up and running,
But
but how about until most people get a return on investment?
yeah, so Medicare, we've seen payments within 2 to 4 weeks. Same thing with commercial.
Okay.
So the break even process is fairly is fairly quick based off their investment. If you're using RPM and you're paying for devices, depending on the way that you're licensed them, sometimes we see 2 to 3 months.
Hmm.
Transparent. The majority of our practices are generating, or at least cash flow positive, if not generating additional profit within 2 and 3 months.
Can you specify for the docs listening when you say if you do
Mm-hmm.
RPM? Okay, we understand you mentioned what that is, but what is it exactly? What are they looking at? What parameters? What gets measured? What
Yep.
data point are we looking at that gets recorded?
Good question. So RPM is, oh boy, I've jumped all over. I mean, it's exciting, but RPM is remote physiologic monitoring. So it is the monitoring of physiologic data. So you will look at blood pressure, pulse ox, uh, the glucose levels, weight sometimes falls into physiologic, and what they'd be looking at is individual numbers, so the
Hmm.
physiologic numbers, and changes over time. That is typically physiologic monitoring. And then it has to be collected by some sort of FDA approved medical device. So it can be connected by a Fitbit. It can be connected by an Apple Watch that's using Cardia. So it has to be a medical device.
So I know a colleague who is doing this, and
Mm-hmm.
he tells me in his practice he does this specifically for patients on opiates, and he has a very heavy opiate practice.
Mm-hmm.
So, but he won't do it for most other patients unless maybe they're taking some medication aside from an opiate that could do something like this.
Mm-hmm.
He said he's worried if he gets audited, he doesn't want to be accused of overutilizing the codes. And if someone's on an opiate, well, it makes sense. Monitor their vitals and this and that because it could affect that.
Mm-hmm.
So, I mean, that's just his take. He's not doing this to every single patient whose insurance
Mm-hmm.
will pay for it, and probably
Mm-hmm.
shouldn't do that because you could be subject to some sort of clawback or whatnot. I assume. Um, but I just wanted your take on that. Do you find most docs are practicing like this, or some
Yeah,
people
I
just
mean,
do
I
it
think
across the
wherever
board?
it's, well, I mean, I think it depends on your practice makeup. There's some practices that we work with that, like, 80% of their practice, there's a medication management component.
Sure.
And then in that case, it is medically justifiable to have 80% of your practice on this because it's remote therapeutic monitoring, remote physiologic monitoring. And so the safety of the patients. So the question is whether it's where it's medically beneficial and necessary.
And what about patient compliance? Is it an issue?
I think it's all about patient education and value. So a lot of we take a lot of pride into building a product that provides value beyond just data collection. So
Right.
our program is about, meeting the patient where they're at, providing them access to additional resources, providing nurse guidance and support. So for us, compliance is just a part of the program that we offer. There is then the other question of compliance is, do patients feel like you're actually using the data to enhance their treatment? If the data is being collected and they're getting bills for it through their insurance, and it's never once discussed, compliance is going to be crap.
Right.
But if the conversations or the data is informing the treatment decision making and is being used even once or twice, saying, hey, I saw that you had elevated levels throughout the month, and the nurse noted that you're under a lot of stress with your housing situation, like that can go a really long way into increasing compliance.
Got it.
Across the board, though, however you were working with or whomever you're working with, or you're evaluating, ask for EOBs. Make sure that the person or the group that you're working with has done this before. It is a process, and especially if you want to reduce the amount of friction and clinical burden for your team, you want to know that from start to finish, your partner has done this. They know how to document this correctly. They know what codes to be using correctly. All of that is really important. And when done correctly, there is substantial impact. A practice that we were working with in Oregon had 176 billable patients. And based off of the CMS and Medicare rates we have with that practice, looking at $24,000 in new revenue just based off of
collected.
CMS.
That's not the
Well,
not
that's
the billable.
actually so that's billable, but it's actually higher than this because it's not just Medicare that we are billing on that practice. And so two payers were seeing substantially above Medicare rates.
Wow. Impressive.
And the CMS, the Medicare patients, we're seeing 99% success rates. They're not kicking them back because we're using the codes correctly and effectively. And there's impact. But the second reason practices are utilizing services like this is for insurance and federal regulator purposes. So if medication management is a component, making sure that you can validate and prove how and why these opiates are being prescribed, that they are being prescribed correctly, and that these patients are being longitudinally monitored. And then especially as payers are requiring more and more information and data before they're allowing or denying services. These types of data points collected consistently at the required cadence, not something your team needs to remember to have each time, is quite valuable. And so being able to have these types of scores, whether it's ODIs, PROMs, PHQ-9s, functional indexes, available in your EMR when your team needs it for pre-auths or otherwise, can streamline a lot of processes. And then, lastly, enhanced care. So at the end of the day, we want to make sure that we're providing patients the best care. We know that patients often need more than we can give them in the period of time that insurance typically pays for a visit. And so to be able to allow them to have that concierge level care, those connection points, access to care modalities that you want to be able to offer, a lot of these codes and services really allow for that, allow for the time. And I'm not one to, frequently pat myself on the back, but when you do a lot in care and feel like most of what you hear is thankless and is negative, being able to hear, doing programs like these are the best thing that I've done for myself makes it feel like these codes definitely have purpose and are there for a reason. So I've been talking a lot and I want to hear from you. So either David or others, Q&As are now open. Throw questions my way.
Yeah, we have a question. They want to know can you explain to them how relevant it is to the pain practice? They do telehealth for follow-up visits and code level 3. I mean, as Rachel, I'll let you feel this, but as Rachel mentioned, this is not telehealth. This is something completely different. Rachel, can you give them the actual play-by-play Remember, not everybody listening saw your prior webinars, which I encourage you
Sure.
guys to do so. Maybe the first one probably went in depth the most about what exactly the remote patient monitoring is, but if you could
Mhm.
just give a brief account.
Yeah, sure. So these codes are supplemental codes. They do not replace telehealth or televisit codes. What they do is they create remote care and longitudinal insights in between visits. So remote patient monitoring, remote therapeutic monitoring, all of these codes are data collection codes that are delivered either through software or through hardware. So physiologic monitors. In our case, we do remote therapeutic monitoring, so delivered through a mobile application. And they are normally reviewed and supported by external partners and provide new insights and valid and documentation for patients and providers.
So,
They
Rachel,
are not a
practically,
replacement for traditional care. They can be billed with office visit codes and E&M codes.
practically speaking, you have your patient on long-term opiate therapy, let's say.
Yeah.
They
Mm-hmm.
come in, you talk to them about the monitoring, and this would be RTM at this point. What you're going to do if you wanted, or if you want to
Yes,
do the
sure. Yep.
physiologics, actually, maybe
Yep.
you want blood pressure and all that. You set them up the first day. You could bill an extra code for that initial
Correct.
conversation, correct?
Yep. You
In
order
addition
this
to your
like you
level
would
3
order.
code.
Exactly. You would order this service or the solution just like you would order an MRI or a CAT scan.
But you're the one billing for it. I'm not billing for MRIs or
Correct.
CAT
Correct.
scans.
No, but
So,
you're like placing an order referral for it.
right, but there's a code for that conversation, and you document the
Correct.
conversation in addition to
Correct.
your office visit, which is payable on the same day.
Correct.
Okay. And
And it
then,
can be it can be telehealth as well. It doesn't have to be in person, but it has to
fair
be an
enough.
active patient.
And then they get set up with the app and whatever. If you're monitoring their blood
Mm-hmm.
pressure at home, I guess it's a blood pressure device, pulse ox.
Right. Mm-hmm.
Okay. They
Yep.
have this equipment, which your office lays out the money for, correct?
Right. I mean, we traditionally don't do our physiologic monitoring as often. We mostly do therapeutic monitoring, but yes,
Okay.
in our
So
case,
therapeutic,
just use.
sorry. So therapeutic monitoring has less overhead because there's less equipment.
Yeah,
They're just reporting their
correct.
pain scores over the course of the week, the time of the
Mm-hmm.
day, maybe any side effects. And then
Mm-hmm.
I think on a previous webinar, we discussed one patient, I think, who maybe like was having either breakthrough pain at a certain time or some other side effect, and it was picked up by your staff and then it was addressed at the office visit. So, or by the doctor's staff, who's reviewing the data.
So in our case, we have nurses who are operating under the general supervision of that doctor. So we're providing that additional resource. But the doctor is the one who is billing for the services and is reviewing this high level data.
So the data is compiled by the nurses or the computer
Yes.
program, and then it goes
Mm-hmm.
to the doctor to review, or him or his PAs can review it, right?
Yep. Yep.
And they can build that out. So now they're
Mm-hmm.
getting paid for the data review, which can occur every month.
Correct. And the nurse
And
call and review, which also happens every month. The data review, the data, they're getting paid for the data transfer and
okay,
then the review and interaction with the patient. The data transfers every 30 days. The uh, monitoring and conversation is every calendar month.
so how much time does it take for a PA to review this stuff, and how much does the practice make billing all these additional codes on
Yeah,
average for
good question.
Medicare?
So we take a lot of pride in making sure that the data is like easily digestible and actionable, and that the notes have almost like a TLDR, too long didn't read, at the top with just like the most pertinent information. And then all of the other information is there should you need it or want to refer to it in the
Okay.
future. So we see nurses or PAs, NPs going through this, a couple minutes at a time. And then
Right.
going at the next visit with the patient, also utilizing that as a conversation piece. And then billable revenue, as I mentioned, we're looking at between about $80 on the low end for RTM, to about $220 on the high end per patient per month.
Okay. Not bad. So, okay.
I
So
don't know if
Rachel,
that
yeah, I think
if that
no, I think
answered your
that's great.
question.
It did. It
But
did.
feel
Because
free, if you want to, the person asking this question, you can also email me, call me, whatever. If you want me to get into more specifics or clarifications, we can also share some of the previous webinars.
yeah, guys, Rachel is very familiar with this, and she's at Aspen. I've seen her at NICIP. She's gone to a lot of the pain meetings. She understands our world, and she's a really good resource. Even if you're not going to use her services, she can still point you in the right direction and explain things. But Rachel, yeah, I was going to say, if they want to reach out to you, here's Rachel's contact information. Rachel, in closing, is there anything else you want to add before I wrap it up?
No, I mean, I think we probably will be talking again in about 2 months in November when this is finalized, when this physician fee schedule, 2024 physician fee schedule is finalized. And at that point, I can, let you know where everything lands. If there's anything that wasn't there before that's really exciting, I'll be sure to let you know. And please just, I said this is like I have an open line of communication here. So if there's any questions that you're navigating, if you as a practice owner, as a clinician, don't know what this really means, or if this is something that could work in your practice, please just shoot me an email and I can help you troubleshoot, not as a sales call, but as something that I care passionately about. So thank you. Thanks, David, for having me again.
My pleasure. It's always a pleasure to have you. And yeah, this replay will be available on the Pain Exam website, the YouTube channel. And I just want to thank everyone who joined us and spending time with us. And hope to see you guys at the conferences or the courses. Just go to the Pain Exam site. You'll see everything on the events page. Thanks again, Rachel. It was really nice having you. And have a good night.
Thanks.